that, I'm going to turn it over to Dr. D and we'll just get moving because this is something as a 30 this year, 30-year-old survivor. This is directly pertinent to me. And so I'm excited for the conversation. Dr. D, it's all yours, sir.
Yeah. Okay, thanks. Hi, I'm Dr. Alex Del Rosario. I'm the medical director of the North Palm Springs HIV clinic here. And I oversee the care of about nearly 1,000 HIV positive patients now. 99% are gay male. And that's what we do here at this clinic. It's primarily HIV positive gay men. And what we're going to do today is talk about HIV and aging. And we're going to take a little bit of a stroll through memory lane here, and as far as where we have come from as far as the HIV. When we take a look before where we are at the evolution of HIV, the HIV care has changed over time. There on the very far left is from about 1981, 1986. That was the ancient dark ages of HIV when we didn't even have a name yet for what we were dealing with as far as HIV. And young gay men in the prime of their life were dying. And we didn't even know what was causing it. In the middle there, 1996 is when we first had the cocktail. We actually had a group of medications which could treat HIV, and that's when things sort of really turned around. We saw a real decline in the death rate. But we started seeing is long-term consequences of our HIV medications. Up at the top there, middle picture, we see the facial fat wasting that happens in HIV, and there's a lot of other changes that happen. Those were the first physical ones that we could see. But as the epidemic has progressed, and as our treatments have improved, what we're now seeing is the longer-term consequences of HIV, because we HIV positive patients are not dying of HIV anymore. We are dying of all the boring things that everybody else dies of heart disease and cancer, but it's happening to us sooner, and we have higher incidences of these comorbid conditions, which we're going to talk about. But now in the current era, on the far right there, we have pretty normal looking people who are HIV positive that we can treat, and for the most part, they live good, normal lives. But over time, what we are seeing, the longer that they are positive, they have these issues which make aging a little bit more of a challenge in our HIV positive population. And here in Palm Springs, we have a lot of older HIV positive men, and we have to deal with those comorbid conditions. And today's lecture, we're going to talk about some of the issues that HIV positive men face when they are aging. Okay, so way back when, again, at the beginning of the Dark Ages, this was a clip from an article way back from 1981, when a very young Michael Gottlieb, who is oftentimes regarded as the father of HIV because he recognized one of the symptoms first, described a condition of a very unusual pneumonia, which we now call PCP pneumonia, in gay men in Los Angeles. And this was one of the first reports of one of the consequences of HIV, the very common PCP pneumonia that used to occur in HIV positive men, and it was often the cause of death for HIV positive men before we had a treatment for HIV. So this was way back in 1981. And again, these were pictures here from Life magazine, but this didn't show up in Life magazine until 1990, when the rest of the United States saw what the gay community was going through and the horrific conditions that these men endured, and they essentially looked like concentration camp victims. It really decimated the gay population. But we now have medications for them. And this is a graph, this is from the CDC, which shows in blue the classification of stage 3 AIDS, which is an advanced classification of AIDS, the death rates in green, and the prevalence rates of HIV and stage 3 in orange there that's going up. So this is going over time. This stretches from 1985, way back in the Dark Ages, to 2021. Okay. And what I'm just going to show here is the progression of some of the HIV medications. We didn't actually have AZT until 1987. And that was the first drug we had for a very long time. And a lot of people probably remember AZT as a horrible drug to take. We dosed it way too high back then. We had people to get 5 times a day. AZT, if you didn't realize, it was a recycled chemotherapy drug. It was that difficult. It was used originally for chemotherapy, but we also ended up using it for HIV. We got a whole host of other drugs, which were all belong to the same class of what we call nucleoside reverse transcriptase inhibitors. And even though it took a long time between AZT in 1987 to 1991, we saw that the death rates were going up. But once we got some of the other HIV medications, even before we had the cocktail, the death rate started to go down. So we didn't really realize it back then, but just those simple, ancient, hard to take drugs actually did start to affect the death rate back then, and it started coming down. We didn't actually get the combination therapy, what we would call the cocktail, until 1996, when we had now 3 classes of medications, non-nucleoside nucleosides and protease inhibitors. And way back then, the only protease inhibitors were ritonavir, which is Norvir, and indinavir, which is Crixivan. That down there, that little box in the lower right shows you all the different classes and the color coding that we're using here. So it wasn't until 1996 that we actually had the cocktail that showed up there. And when you can see that now that we have the cocktail, that really brought the death rates down. And then we started thinking about HIV as a manageable, treatable disease. We got a whole host of other new medications later on that really, again, brought the death rates down further. We started seeing much fewer classifications of actual AIDS. People then were diagnosed with HIV. They weren't actually having AIDS, which was the more end-stage terminal version. When you had opportunistic infections, T cells lower than 200, we started to see people actually improve from that. Then we got a whole host of other medications, and again, death rates continue to go down. Now we have here some of what are called the entry inhibitors. You might remember Fusion, that was an injectable HIV medication. Cells entry, which is the MCV of Maraviroc. Those are newer, easier to take medications. And as we progress, the medications get better, they get easier to take, and fewer side effects. But again, what we started realizing is we're having long-term side effects from these medications. These last 3 here are the new integrase inhibitors, Icentris, elvitegravir, and Tivicay that are out. Very easy to take, very well tolerated medications, don't have nearly as many of the side effects as the older ones. And we're getting some newer medications. That TAF is a new improved version of tenofovir, which is less toxic to the kidney, because what we found out is the older version was toxic to the kidney and the bone. And that's, again, some of the long-term side effects that we have to deal with. And then some of the newer medications that are out here, which are now injectable, long-acting, long-term medications. So again, this is more for the HIV treatment professionals that we're going to talk about. But this just gives you the history that took a long time to get to the newer, easier to tolerated medications that are now sometimes one pill with 2 or 3 medications in them, much easier to take than the old AZT way back then. And what I'm going to show you here is just, it's a little overwhelming, but this is the number of HIV medications that we have. The ones that we actually use, the commonly used ones, are on the blue on the top column there, and all the different classes that we have. The ones in the red are some of the older ancient ones that we actually don't use anymore because they're so difficult to tolerate. They cause anemia, they cause nausea, they cause diarrhea, they cause facial fat wasting, they cause all sorts of things. So we don't use those anymore. But unfortunately, the people who have been put on them, because those are the only things we had back then, still have all of those side effects that they have to deal with. And sometimes those side effects don't go away, even if we take you off the medication. So especially here in Palm Springs, because we have an older population that was in San Francisco when they were in their 20s or 30s, or New York, and they've now retired to Palm Springs, they had been on some of those older, more ancient medications, which had all these side effects. And so you need HIV treatment professionals that are familiar with some of those ancient medications and what the side effects they had. Sometimes, especially for the more experienced HIV positive patients, been through many different regimens, Sometimes our younger doctors may not be fully aware of what the side effects of the older medications are because they weren't using those medications in practice when they're in practice. So sometimes you have to get an HIV doctor that is familiar with some of the side effects of the older medications. And then down at the bottom are some of the newer ultra long acting medications, the Sunlenca, which is lenacapavir. That was just recently FDA approved earlier this year. It's an ultra long acting every 6 month injection. Right now, it's reserved for very treatment experience. But what they're looking at is maybe even turning that into PrEP. So we may have a PrEP injection you take once every 6 months. So they're looking at that. And then there's another one, the lenacapavir plus what's called a BNAb, a broadly neutralizing antibody. Those are 2 every 6 month injections, which we may be able to use to treat with HIV positive patients. Right now, you can get Cabenuva, which is an injection every 2 months. But the lenacapavir and the BNAb, that may be a once every 6 month injection. So you only see your doctor twice a year to get an injection for your HIV, and you don't have to take any pills. So that's what's probably coming in probably another year. We're hoping that we'll be out in another year. So HIV treatment is progressing from some of the earlier to take really difficult to tolerate medications to some of the newer 1 pill once a day medications. Now we're moving to ultra long acting injectable medications. So it's evolving over time, but we have to deal with the side effects that these have caused. This is, again, a graph from the CDC, which is showing that the death rates from HIV are declining and the incidence of HIV is the new cases are declining. So again, this is just a testament to the remarkable medications that we have that are helping us, our HIV positive patients, live longer. But what we're also seeing is that as a consequence of living with HIV longer, we're having some issues that are cropping up that are affecting how our HIV positive patients are aging. So this graph here shows that what we're taking a look at the major causes of death in HIV positive patients. In the younger patients back from 2006, now this is from 2000 data from 2006 to 2016. Back in the earlier days, HIV was still actually a cause in this generation of patients. And what we can see here over time is that as things get better, the things start to improve. So when we take a look at that active graph in the bottom, the gray for the HIV goes down from 6 cases per 100,000 down to only 1.8 cases per 100,000 in 2016. So we're seeing less HIV as the cause of death because what we're seeing is that we're living longer. This next graph shows the older patients from that age 45 to 64. And what we're seeing is that we're not dying of HIV anymore. Like I said, we're dying of all the boring stuff. As you can see here, then the causes of death are going to be cancer, then heart disease, stroke, chronic lung disease, all those other things. So we're not really dying of HIV. In fact, HIV doesn't even appear as the top causes of death for the patients 45 to 64 anymore, because they're doing very well. And again, you can see that over time, there's a little bit of a change in the causes of death, but HIV doesn't appear among them. This takes a look at what the causes of death in the United States are. Number one there is heart disease, as you can see, cancer, then COVID, because this was done during the COVID era, and then unintentional injuries, stroke, all those things. Those are the number one causes of death. But the question is, does HIV affect these causes of death? And unfortunately, HIV gets its grubby little hands into almost all of these causes of death. So when we take a look at the effect of HIV and the effect of long-term antiretroviral therapy, there actually is an effect on the major causes of death here. So when you take a look at heart disease, what we're seeing in HIV positive patients, and we'll go over this in a little bit more detail, is that HIV or the medications, we're not sure which, causes an increased level of inflammation inside our coronary arteries and our aorta, and that contributes to higher rates of heart disease in HIV positive patients. I'm going to show you data that shows that we HIV positive patients are nearly 1.5 to 2.5 times more likely to have heart disease, even if you have 0 risk factors for heart disease. If you have normal cholesterol, never smoked a cigarette in your life, have no family history, and completely normal blood pressure, just because you're positive, you're 1.5. Yeah, you're 1.5 to 2.5 times more likely to have a heart attack or a coronary event just because you're positive. So that's what we're realizing now, and that's what the practitioners who are treating HIV positive patients need to be aware of, is that we have to pay extra special attention to risk factors for heart disease, because it happens to us at a higher rate and also, unfortunately, earlier, about 10 years earlier than the general population. Um, the next thing, we're talking about cancer, the second cause of death. Your immune system is actually your cancer surveillance system. So your immune system helps protect you against cancer. Even though the HIV medications are keeping us healthy and they're keeping our T cells high, we still have immune dysregulation. We're not completely normal. Our immune systems are still a little dysregulated, and therefore our ability to survey and protect ourselves against cancer is diminished. And there are some of the HIV cancers which are decreasing from the ancient days, like Kaposi sarcoma and central nervous system lymphoma. We're seeing a lot less of that. But now that we're living longer, we're seeing a different set of cancers that are starting to affect us. And we'll go over that too. As far as stroke, unfortunately, inflammation and insulin resistance, those are also very common in HIV. We see a lot of problems with insulin resistance in our HIV positive patients. It has to do sometimes with the medications they're on. And again, inflammation, not just in the heart, but inflammation in the blood vessels of the brain can lead to stroke, and that's a major cause of death. As far as Alzheimer's, you think, how does HIV affect that? Again, inflammation inside the brain can cause problems with the blood vessels, which can lead to some dementia. And HIV reservoirs in the brain can cause what's called HIV-associated neurologic disorder, which the treatments are to try and put you on medications, HIV medications, which penetrate the brain. But that HIV also affects that too. As far as diabetes, unfortunately, HIV lipodystrophy, the sort of HIV belly, the Crick's belly that or protease paunch that we used to be talking about, that develops over time, even though you're not on protease inhibitors anymore. And insulin resistance as a result of that, again, leads to significant problems with diabetes, which affects other things like heart disease. So again, HIV affects those things, including our treatment with our medications. Cirrhosis, chronic liver disease. Unfortunately, HIV positive patients are a higher risk for something called fatty liver disease, which is from the fat that is accumulating inside our abdomens. It can then affect our liver and then cause problems with liver disease and inflammation. And as far as chronic kidney disease, unfortunately, some of our HIV medications are toxic to the kidney. So again, the HIV and the HIV treatments can affect this. And you would think that unintentional injury like falls and things like that would have nothing to do with HIV. But unfortunately, again, some of the HIV medications affect bone toxicity and can cause brittle bones. And so as we get older, if you experience a fall or fracture your hip or a vertebrae or a vertebral fracture, you're more likely to have that because of some of the medications that you were taking. So again, we need to pay special attention to the long-term issues that are out there for HIV positive patients to make sure that they age in a healthy way and that the HIV medications we put them on aren't making things worse. So first thing I'm going to do is talk about heart disease in HIV. And again, a big cause of dying in the United States is heart disease. The first thing I'm going to do is going to talk about this study which took a look at inflammation inside the heart. And they took a look at three groups of people. One was untreated HIV versus HIV-infected individuals. And they took a look then at patients who were HIV positive versus match controls who weren't HIV positive. And what they found in here is that all the HIV positive patients had higher levels of inflammation, and as a result, there were an increased risk of dying. That all those numbers there on the right side of the graph indicate that they don't cross one, that increases the relative risk of death and dying just because they're positive, regardless of whether or not they were on medications or not. This second one takes a look at risk factors for heart disease, and again, took a look at a whole bunch of studies. And what they came up with is the bottom there that shows that HIV positive patients are nearly 2.5 to 2.6 times more likely to die of a heart attack just because they're positive, even if they have no risk factors for heart disease. And again, we think that's due to the inflammation that's going on. And again, these are just a summary of all those different studies which took a look at it. Those blue and lines over there to the right show the increased risk factor. The red pyramid at the red diamond at the bottom is a little bit over 2, it's more almost 2.6. That's indicating 2.6 times normal risk factors for heart disease is the conclusion from all these different studies. And I talked a lot about inflammation. This is the pivotal study which shows that inflammation that's going on inside our coronary arteries. So they took a look at 3 groups of patients in this one: HIV positive men who had absolutely no risk factors for heart disease, HIV negative men who also had absolutely no risk factors for heart disease, and then they took a look at guys who had actually known coronary artery disease. And they did a very fancy special test, which we don't normally do on patients. They did something called a PET scan, and they used 18 FDC, which is 18 fluorodioxy glucose, which is radioactive glucose. And they used a PET scan, which is a positron emission tomography scan, to take a look at the metabolic activity inside the aorta and the coronary arteries as a marker for inflammation. So basically what this test was looking for was for inflammation. How much inflammation do these guys have? And they also did a coronary artery calcium scan to see how much plaque these people had built up in their coronary arteries. And that picture there was just showing that what they're looking at. So basically, again, they took a look at HIV positive patients. These were all really healthy, well-controlled HIV positive patients. Average T cells was 600. They were all undetectable. They had mean duration of HIV infection of over 12 years. They were all on antiretroviral therapy. The HIV negative guys, they had the exact same risk factors for heart disease, but they were HIV negative. And then they also took a look at HIV negative guys who had known coronary artery disease. So what did they see? What they saw here is in the blue column, the HIV guys, the purple column, the HIV negative guys, and the pink column there, the guys with coronary artery disease. When you take a look at the first row there, that target to background ratio, that tells you how much inflammation there was in the heart. The HIV positive guys at 2.23 had almost twice as much inflammation as the HIV negative guys. And this was statistically significant. And then when you compare them to HIV negative guys who had coronary artery disease, who either had a heart attack, had a stent placement, who had known coronary artery disease, the inflammation levels in HIV positive men were higher than the people who had known coronary artery disease. So we have a lot of inflammation in our heart if you're HIV positive. And they also took a look at the calcium scores. The HIV positive men had significantly higher calcium scores than the HIV negative men, which means they had plaque building up in their heart and the potential for more significant coronary artery disease. The guys with known coronary artery disease had much higher calcium scores, but again, the difference between the HIV positive and the negative guys was statistically significant. So what we're seeing here is that just because you're HIV positive, you have more inflammation and more likely to have these coronary plaques built up compared to guys who are HIV negative. And this is another thing that they took a look at some inflammatory markers, which we don't normally look at. We know that there are some inflammatory markers that are associated with heart disease. This is one of the ones that they took a look at, which we don't normally check. It's called a soluble CD163 marker. And that's shown on the bottom there, and on the top, the y-axis of the graph is the target to background ratio. And as the level of the soluble CD163 marker goes up, the target to background ratio, the inflammation level goes up. So this tells us that the higher level of inflammation, or this inflammatory marker, the higher level of inflammation in the coronary arteries, and the greater risk for heart disease. So what we're trying to do now is trying to figure out how to use this marker to try and figure out which guys have more of a risk for heart disease and what we can do to decrease this marker and see if that improves the risk factors for heart disease. So the treating inflammation is going to be a big risk, a big risk factor that we're going to be looking at as things go on, as our HIV positive patients are living longer. We're going to figure out ways to how to decrease this level of inflammation and then reduce their risk factors for heart disease. And this shows us the inflammation inside a coronary artery. So this is just taking a look at a coronary artery. That step A shows that the leukocytes, or the white blood cells, actually start to invade the inside lining of the coronary artery. They develop in slide B there. It shows that the T cell lymphocytes join in there. So again, that the T cells actually start to invade this coronary artery plaque. At some point, that plaque ruptures. That's the slide C in the middle there. And then a thrombus or a clot forms, and that's what blocks off the coronary artery. And in the very bottom, when you see that a part of the heart that's affected there. So that can happen just as a result of inflammation, even if you have no risk factors for heart disease. Again, completely normal cholesterol, completely normal blood pressure, no diabetes, never smoked a cigarette in your life. This can happen just because you're HIV positive. So that's why we're taking a look at inflammation. And just last week, the FDA approved actually a very old drug called colchicine, which is used to treat gout, but it's an anti-inflammatory drug. And what they found is that using this drug, colchicine, in HIV negative guys, because the positive guys were not included in the study, in the HIV negative guys, it reduced risk factors for heart disease and a heart attack by about 30%, which was a significant risk factor. So reducing inflammation does decrease your risk factors for heart disease and a heart attack. So that's what we're probably going to be moving towards, is using that in HIV positive patients to decrease their risk factors for heart disease, because we know from these studies that HIV positive patients have higher levels of inflammation. So if we can reduce the inflammation, we're thinking that that's going to reduce their risk factors for heart disease. Only problem with the colchicine for HIV positive patients is that, unfortunately, colchicine can cause diarrhea. Because when you use it to treat gout, you give it to someone in high enough levels to get rid of their gout attack, or until they get intractable diarrhea. So diarrhea is already a problem sometimes for HIV positive patients. So it makes colchicine a little bit hard to use for that. They're trying to use ultra low dose colchicine, but even with ultra low dose, the studies showed that there was still some stomach upset. And then the other problem, again, for HIV positive patients is that all the anti-inflammatories like colchicine can cause problems with the kidney. And again, for our older patients, that's an issue. So there will be a whole host of new anti-inflammatory medications, which hopefully will be better tolerated than colchicine and have less effect on the kidney. But we're waiting for those medications to come out. But that's where the direction of treatment is going. And now we're going to move on to cancer, because again, that's the big cause of mortality in our HIV positive patient population and in general population. So how does HIV affect cancer? Um, Way back when, again, sort of in the ancient days, the AIDS-defining cancers were things like Kaposi sarcoma, central nervous system lymphoma, cervical cancer in women. Those, if you got those and you were HIV positive, that got you the diagnosis of AIDS. Now, in the era of antiretroviral therapy, we're seeing far fewer Kaposi sarcomas. We hardly ever see that anymore. Not seeing any central nervous system lymphomas, and even well-treated HIV positive women have less incidence of cervical cancer if we can get their T cells higher. But what we're seeing now that we have antiretroviral therapy, we're living longer, we're seeing different types of cancers emerge. In particular, human papillomavirus-related rectal cancer and squamous cell carcinoma of the rectum or the throat. We're starting to see that more often. And instead of central nervous system lymphomas and non-Hodgkin's lymphomas, we're seeing B-cell lymphomas, which can occur in well-treated HIV positive men who have high T cells and are undetectable. They can still come down with lymphoma. So some of those are some of the cancers that we're seeing in our HIV positive population. And I'm going to talk a little bit about human papillomavirus, because this is probably one of the cancers that we're worried about the most emerging in our HIV positive men. Human papillomavirus is probably the most common sexually transmitted disease out there. Very, very common. HIV, HPV, or human papillomavirus related cancers in the general population account for about 5% of all cancers in men, 10% of all cancers in women from cervical cancer. But HPV is strongly associated with anal cancer, especially in HIV positive men. 100% of cervical cancers are caused by human papillomavirus, and 88% of anal cancers are caused by human papillomavirus. And in the gay, bisexual, and men who have sex with men population, 98% of all anal cancers were positive for human papillomavirus. So that's basically anyone who is not exclusively heterosexual, you're at risk for anal cancer because of your exposure to human papillomavirus. If you're HIV positive, much higher risk. And one particular type of human papillomavirus, type 16, accounts for 73% of all anal cancers. So HIV, the HPV, human papillomavirus, leads to an infection and malignant transformation of the cells in the anus. It's a multi-step process. The HPV, human papillomavirus, infects what are called the basal cells of the transition zone inside the anus. That's where the dry skin of the external anus transforms to the wet skin of the internal anus. That's where human papillomavirus likes to live. And there's two particular proteins in human papillomavirus, E6 and E7, which actually do all the dirty work, which cause the malignant transformation. And it acts differently in different people. So this is just a diagram of how strongly those proteins interact. If there's a low binding potential of these proteins, they result in something called low-grade squamous cell carcinoma, with intraepithelial lesions, which are non-cancerous. If those human papillomavirus proteins have a strong interaction with the host DNA, then it produces a high-grade lesion. These are what are done through what are called rectal pap smears. And again, this is a special way that we're going to need to treat and screen our HIV positive patients to rule out rectal cancers, to get these rectal pap smears. The problem is not all general practitioners know how to do a rectal pap smear. It's a little bit of a specialized test. It's a moistened synthetic cotton swab that goes in the butt. And what we do is we're taking a sample of cells inside there, and we get something that gets back from the lab that shows either low grade or high grade squamous cell lesions. The problem with this is you have to have the follow-up that goes with this. If someone has a low-grade lesion, that's not considered precancerous, and you just keep track of them and follow them to make sure that it doesn't turn into anything more significant. But if you get something that's a high-grade lesion that comes back on the lab, then you have to do something about it, because that lesion has the potential to turn into cancer. So our HIV positive men, when we do their rectal pap smear screens and it comes back high grade, then we have to send them to a specialist, which can then take a look inside the anus and see if there's any abnormal areas, and they need to biopsy those areas, and then they determine if they come back what are called AN1, AN1, 2, or 3. The level 1, not cancerous, not worried. We don't worry about that. But the level 2 and 3, those are considered high grade and precancerous and have the potential to turn into rectal cancer. You always want to get these things when they're easy to treat on the surface level. Rectal cancer is a difficult cancer to treat. And in HIV positive men, it is a harder cancer to treat with less of a response rate. It is treated generally with combination of radiation and chemotherapy. The butthole is never quite the same after being treated with radiation, and chemotherapy is really rough, and it can knock the T cells down a lot. So we hopefully don't get to the point where we have to use treatment for cancer, but unfortunately, we're starting to see more of this in our HIV positive patients as we're living longer. This is the cancer that we're starting to see more often. And then the last thing I'm just going to go over, diabetes. Again, more of an issue as our patients are aging. We're seeing problems with diabetes, blood sugar, and diabetes affects all sorts of other things. It can increase your risk factors for heart disease. Being diabetic nearly doubles to quadruples your risk factors for heart disease. It increases your risk factors for problems with the brain, as far as having strokes and vascular insufficiency of the brain. It increases problems with potential risk for kidney failure. So diabetes affects all sorts of things. And this is, again, an example of one of the receptors which some of the HIV medications can affect. It's called the GLUT4 receptor. This is the receptor which pulls blood sugar out of the blood and brings it into the body so that the cells can utilize it. Unfortunately, some of our HIV medications affect the ability of this receptor to do its job. Some of the protease inhibitors like atazanavir, which was Rayataz, Norvir, which was ritonavir, and darunavir cobicistat, which is Prozista, all of these interfere with the effects of this glucose transporter. So people end up with more glucose in the blood. They can't pull the glucose into the cells where it can do its job that it needs to do. And that high blood sugar level starts to result in problems. And again, so sometimes to manage this, we need to sometimes try and take patients off their protease inhibitors, use a different type of medication. And sometimes we need to use diabetes medications more often in our HIV positive patients. And you might have heard some of the newer diabetes medications like Ozempic out there can actually help with weight loss. And we're starting to use those more in our HIV positive patients to try and get their weight down to get rid of their diabetes so don't wind up with the consequences of diabetes. So again, just in treating our HIV positive patients, we have to be aware that there's all sorts of things that HIV can affect long term, which will impact a patient's mortality and may cause them to die sooner if they're not treated, like they're surveilling for cancer, like making sure we're taking a look at their risk factors for heart disease, all of those things. So again, just to bring this final slide back, unfortunately, HIV gets its grubby little fingers into just about all the aspects of the risk factors for the major causes of death and dying here in the United States. It can affect the heart from inflammation. It can affect cancer from a lack of immune surveillance of getting rid of the cancers. It can affect bone toxicity, increase your risk for fracture. All of these things are affected by the HIV medications and the HIV process itself. So it's important to have a conversation with your HIV treating doctor about what are the things to do to minimize your risk factors for dying of heart disease, cancer, stroke, chronic liver disease, things like that. Because sometimes the way we treat the HIV can actually have an effect on this. And a lot of, unfortunately, HIV positive patients, through no fault of their own, start to develop things like diabetes, chronic kidney disease. And again, we need to, again, change the HIV medications around a little bit to try and address those. And hopefully some of the newer, longer acting medications will have less of an effect on this. But again, that remains to be seen. So I know that was a little scientifically intense, but I want to make sure we leave time for some questions to ask.
Absolutely. Thank you, Dr. D.
Mhm.
We have a few questions in the chat, and then we'll open it up for live questions and answers as well.
Okay.
One thing is there, in regards to cardiovascular health and this scenario, I know one of the new things that is myself included, I have my cardiovascular specialist is recommending statins and those kind of things, even if my numbers are slightly above, but they're still below the norm. Can you speak a little
Right.
bit more about statins in our world today?
One of the reasons why statins are so good is that they not only lower cholesterol, and especially the high potency statins like Lipitor, which is torvastatin, and Crestor, which is rosuvastatin. Those are considered the high potency statins. They lower cholesterol. They've also been shown to decrease the atherosclerotic plaque buildup in the heart. So when you check a guy's calcium score, it actually gets better over time if they're on Lipitor. But the big thing, and again, because we're talking about inflammation, we found is that the high potency statins like Lipitor and Crestor actually reduce inflammatory markers. So there's some particular inflammatory markers they reduce called C-reactive protein. That's one of them that they reduce. So we think statins do such a good job because they actually reduce inflammation. And we HIV positive folk have more inflammation in our coronary arteries. That increases our risk factors for heart disease. So that's why we think statins do such a good job with that. But the story is that in that one that I showed you with the PET scans where they took a look at those coronary arteries, some of those guys were actually on statins and they still had high levels of inflammation. So there are all sorts of other inflammatory markers that we don't normally check that can also affect this situation. So that's why we want to try and take a look at other things like this soluble CD163 protein and ways to try and identify patients that might be at a more of an increased risk for heart disease and how to manage that. Um, and the other important thing, uh, when we decide to put someone on a statin, we use something called the atherosclerotic risk calculator that calculates your risk for heart disease. It'll actually spit out a number that says you're low, intermediate, borderline, or intermediate, or high risk for heart disease. And we generally don't put people on statins until they're intermediate risk for heart disease. But the big issue, again, that we're seeing from all of these studies that shows HIV positive patients are at a higher risk for heart disease is that your HIV status is not at all taken into account in that risk factor calculator. So just because you're positive, you have, well, like I said, up to 2.5 times more risk for having a heart attack. But that risk is not taken into account in the standard calculator that we use. That's why your doctor may suggest a statin, even though you're sort of on the fence or borderline just by the recommendation. But because you're positive, it is better to put you on a statin to decrease the inflammation.
Oh, that's great. Thank you very much. Um, In regards to supplements, I have a couple questions here. Which supplements would you recommend I take as I grow older with HIV? And kind of corollary, so should people with HIV consider telomere boosting supplements? I'm not sure what that is, but
The telomere is a part of the cell which is used to help in cell division. Young, healthy cells have long telomeres. As the cell divides over time and time and time, and those telomeres get shorter, they get used up. So the telomere length is a way to tell how young a cell is. And one of the things that they took a look at in HIV positive patients compared to normal patients is that HIV positive patients, we have shorter telomeres, which means our cells are older compared to other people who aren't HIV positive. And when you take a look at it, on average, HIV positive men compared to HIV negative men the same age, we are 20 years older on a cellular level because our telomeres are much shorter. So the whole idea behind this, taking these telomere supplements, which unfortunately we don't have a lot of data on, is to try and make our telomeres last longer and not get used up so fast. But what we're seeing is that HIV tends to accelerate the aging process. And on a cellular level, like I said, we're about 15 to 20 years older than men who are our same age who are HIV negative.
great, thank you.
But right now, as far as which supplements to take, we don't have a lot of randomized data on which is better. So,
Yeah, I know one of
because
the conversations that are taking place among many patients is looking at, are they taking a lot of supplements and overdosing in a sense of over the counter because they read something on Dr. Google,
well, the
and
problem
then,
with the over-the-counter supplements is they are not FDA regulated. And so they can say whatever they want, and it actually doesn't matter because the FDA doesn't regulate them. There's been a lot of move to try and regulate dietary supplements, but the dietary supplement industry does not want to be regulated at all because then they'd have the FDA, taking a look at them. There was a study that the FDA did to take a look at. They took a look at a random number of dietary supplements, and they checked to see did they actually have the advertised ingredient in them. And in this study, it did not have the advertised ingredient in about 20% of the sample that they looked at. And they also found higher levels, unacceptable levels of things like arsenic and lead in some of these things. So it's buyer beware when you take a look at dietary supplements here in the United States because it is a completely unregulated business. If you want to get good quality dietary supplements, get them from the Federal Republic of Germany because Germany, the Federal Republic of Germany, actually looks at what's in them and they regulate dietary supplements. So if you're going to get them from the Federal Republic of Germany, you're probably more guaranteed to actually get what's advertised in there.
great, thank you. A couple questions here on bone. Let's talk about bone screenings and what you should do with HIV related medications, which impact obviously bones. What's your thoughts on kind of
So the big
bone?
one that we worry about is tenofovir, the tenofovir disoproxil fumarate, which is in Truvada. So Truvada, there's unfortunately from wherever standpoint is, there's a lawsuit out against Gilead because Truvada can cause bone problems and it can cause kidney problems. Truvada was also in a tripla. So if anyone who was on a tripla for 10, 15 years, you're going to have some bone issues and you might have some kidney issues. If you're taking Truvada for 10 or 15 years, yeah, you might have some bone or kidney issues. Um, they have come up with a new version of Truvada, which is Descovy, which is tenofovir alafenamide, which is more kidney friendly and more bone friendly, but it still has some toxicity. So it depends on the total amount of time you've been on them. So if you were on a Truvada or a triplet regimen for more than 10 or 15 years, you should have your doctor do a bone mineral density test on you, which is essentially a fancy X-ray. And all that does is it checks to see is the density of your bones, the expected density for a man your age and your race. And oftentimes what we see is that the bone mineral density is less. If it's one standard deviation below normal, that's considered osteopenia, which is decreased bone mineral density. If it's two standard deviations below normal, that is frank osteoporosis, which increases your risk factor for bone fracture. Because what the tenofovir in those drugs did is it caused your kidney to waste too much phosphate in the urine. So you're peeing out too much phosphate in the urine, and there's not enough phosphate in the blood to combine with calcium to make bone, because bone is made up from calcium and phosphate. So you have something called what's called a Fanconi syndrome from these medications, and that's how we get the bone density scans approved. Is you need to put all the right diagnosis to get those approved in.
Great, thank you. Let's talk a little bit about HIV-related neurological issues. That seems to come up quite a bit.
Yeah, unfortunately, like I said, what we're seeing, there's a condition called HAND, HIV-associated neurologic disorder is what it stands for. And what we're seeing is over time, as our HIV positive patients are living longer, we're seeing patients complain of cognitive dysfunction, problems thinking, problems with memory, problems with planning, um, uh, sometimes a lack of coordination, that are all occurring, and we didn't really have a good explanation for it. Um, what we see when we take a look at CT scans and MRIs is that sometimes we see more than the expected amount of atrophy in the brain, that the brains look a little bit more shriveled up than we would expect for the patient's age. And for a longest time, we were associating that with just the HIV process itself. And before, what we were treating with is we tried to put people on HIV medications which penetrated the blood-brain barrier. Not all the HIV medications penetrate into the brain. So the thinking was that putting people on more central nervous system penetrating medications would help. That has unfortunately proven to be not so beneficial. We still try and put people on medications which penetrate the brain. What we're starting to appreciate again as we're getting more data is that HIV accelerates the aging process. And some of the things which we can make better, which affect the brain, are blood pressure, cholesterol, diabetes. Those are the big things. So when your cholesterol levels are high, they can clog up not just your coronary arteries, but they can clog up the arteries that feed the brain. So the brain doesn't get enough blood. Diabetes affects the very small blood vessels in both the heart and in the brain, and you can get little micro mini strokes because of that. And then again, if the blood pressure is too high, that can also cause microvascular damage to the brain. So when we take a look at the CT scans and the MRI scans for our older HIV positive patients, we sometimes see evidence of what we call microvascular damage to the brain, which is caused by, again, diabetes, cholesterol, and blood pressure. So those issues, again, very common problems in HIV, and we need to pay extra special attention to them and really treat those aggressively so that we don't lose brain matter to these little mini strokes which can occur. Again, neurocognitive issues very very big, and especially with the COVID, some people have long acting COVID, and they can have a or long term COVID, and they can have brain fog complaints. And again, we're thinking that is due to inflammation caused by the COVID. We also have inflammation caused from the HIV. So the underlying thing is inflammation is bad. So we're trying to find out medications and treatments that can lessen that.
Great, thank you. A question that came in said, did the researchers happen to separate number of responses by medications taken, i.e. more CAD inflammation in clients taking Biktarvy, or does HIV treatment medication not play a part in this?
What we're seeing is, unfortunately, that some medications are more to blame than others. So again, that whole timeline of medications, way back when we had AZT, was the only thing that we had. We used it sort of exclusively, but it caused anemia. It would cause bone marrow failure, cause nausea. People vomited on it, so that's why we don't use it anymore. Some of the better tolerated medications we've been using, like tenofovir, Truvada, that was very well tolerated. It took up the huge market share, but over time we're finding, oh yeah, it's causing kidney problems, it's causing bone problems. So over time, unfortunately, it takes time for us to figure out the long-term side effects of these medications. So there is a shift in the way that we treat HIV positive patients. So if I have got a patient that comes in and he has some underlying kidney disease, I'm not going to try and use tenofovir, and I'm trying to put him on a different medication which doesn't affect the kidney. Um, We only have a few nucleoside backbones left, so that would usually be something like Epsicom, which contains abacavir and lamivudine. But what we are seeing is that, again, some data sets are showing abacavir may be associated with some increased risk factors for cardiovascular disease. That was in the DAD data set. A reanalysis of that showed that it was probably a little bit overblown when initially looked at it, but there's still some residual effect of on heart. So that's why we're now trying to move to these other non-nucleoside containing medications like Cabenuva, the injectable 2-month medication, or the thing that we're looking forward to is that lenacapavir and BNAB, which is an every 6-month injection. And we're going to see, does that cause less cardiovascular risk? Because again, we're seeing cardiovascular risk in our HIV positive patients. Another issue for the heart in particular is other things which we use to treat HIV that aren't the HIV medications, like testosterone. A lot of our men are on testosterone replacement, but unfortunately, that causes a unique suppression in the good cholesterol. When the HDL cholesterol, the good cholesterol, goes below 40, that is an independent risk factor for heart disease. So we have to be very careful with that in our HIV positive patients. And we now know that just being HIV positive increases your risk for a heart attack. So we have to be taking a look at things like the testosterone replacement with a little bit more caution than we were before. Before it was like we didn't think we were going to live long enough to have to worry about heart disease and dementia and those things. But now we're living long enough that we have to worry about those things. So again, it's getting the right balance with the type of medications you're using and try and minimize the long-term toxicity of some of the medications, including the medications we use in HIV positive patients that don't necessarily treat HIV itself, like testosterone replacement.
Great. This is a good question. It says recommendations for slowing aging beyond the usual diet, exercise, lifestyle recommendations. Is there anything else out there that they should be taking into account?
Like I said, that's an emerging field. We don't have a lot of data on that yet. There are a lot of purported things out there. Metformin is now the latest, greatest anti-aging thing out there. There's a lot of clinics that are having people take metformin, which is a diabetes medication. So I have my young millennials are coming, hey, can you put me on metformin? I want it as an anti-aging. I was like, you're only 30, you're worried about aging now. Um, but there is some purported benefits of metformin that can help as far as slowing the progression to diabetes. It does all sorts of other things. It is reasonably well tolerated. So there are some medications out there that they're getting more scientific study. But like I said, right now it's a little too soon to say which ones are going to be the ones that are beneficial. We know that maintaining, as we're getting older, maintaining your health, moving around, your joints, tendons, all that stuff, you use it or lose it. If you're not exercising, you start to develop atrophy of the muscles. The tendons are not as strong, and you can run into problems with your joints. So we want people to exercise. We want people to maintain a good amount of lean muscle. We want them to try and decrease the fat in their abdomen because abdominal fat, whether or not it's intra-abdominal fat or the sort of roly-poly Santa Claus fat on the outside, that leads to problems like diabetes, which again, as we were seeing, affect all sorts of things like risk factors for heart disease and microvascular damage.
Thank you. Another thing in regards to sleep, is there any correlation with like, different sleep aids you've taken over the years or with HIV drugs in particular, or is it?
The problem that, again, sometimes we have to treat some of the HIV medications caused insomnia. So anyone who was on Tripla had very vivid dreams, but they also had insomnia. So they were all on Ambien, and they run into problems with Ambien habituation and addiction and benzodiazepine addiction, which causes its own problems with sleep. So again, we're trying to move to medications which don't cause problems with sleep. The very commonly used integrase inhibitors like Biktarvy, Triumeq, Divicay, those can cause insomnia. So you never take those at night. You're supposed to take them in the morning because if you take them at night, you won't sleep. So again, you have to have a practitioner that knows the potential side effects of the medications that can advise you when to take them. Good sleep is important. We live in a very busy society and we are chronically sleep deprived. No one ever really gets 8 hours of sleep anymore. So that's what we really recommend for our patients to do is to get a good amount of sleep. And again, the thing that we're seeing in our older aging HIV positive population is they're putting on more abdominal weight. We're seeing more sleep apnea. So one of the things that we need to do is if we're seeing sleep apnea, there are problems with not breathing well at night, having morning grogginess or feeling sleepy during the day, we have to assess them for sleep apnea and treat them sometimes with a CPAP or a nasal mask, trying to help them breathe. Because again, those are problems with aging that you have to address.
Great, thank you. That was all the questions in the chat. I know we're just about at time, but we do have room for a question or two from the audience. If anyone has a live question, just please unmute and ask the doctor. And if not, well, there we
So I
go.
just wanted to make sure that the patients know that just make sure you talk to your doctor about other things other than your HIV. And sometimes you are seen by maybe an infectious disease doctor that treats only the HIV and doesn't do the other internal medicine stuff like diabetes, hypertension, cholesterol, those things. It's important to get a more integrated approach. So you might want to make sure you're treated by someone who is familiar with HIV and who is also familiar with the long-term consequences that are emerging from HIV, because it's really more in the purview of family practice and general internal medicine to manage all the things like diabetes, cholesterol, blood pressure, but those have a big impact on the long-term morbidity and mortality for our HIV positive patients. So it's important to make sure you get a good integrated approach to that.
Great. I did see someone on mute. Rick, did you have a question? Or I know you were very thankful. There's a lot of thanks coming in from the audience in the chat for the all the information you've been providing. But if anyone has a live question, or
Yes, I have a question, please.
I can't really hear you, Rick. Are you there?
So you can't hear me?
Yeah, if you can speak more into the speaker, I can barely hear you.
Yeah, you can't hear me.
Sorry, Rick. You're almost
Let's see.
you're.
Can you hear me now?
Yeah, there we go.
Yeah,
Better, yeah.
okay. I was just going to ask regarding the bone. It, it, uh, no, actually, not what I'm going to. What I was going to ask: are there any studies that show the average age of death for HIV positive individuals now, as compared to the population? Um, and then if they're 20 years older physiologically or 15, is our age, is it around 75, is it around
No, I said when
so
you take a look at different things, the telomere length, we're about 15 to 20 years older on a cellular level. And what we're seeing as far as things like the cardiovascular risk, they tend to be happening about 10 years sooner. So heart disease risk, which you don't normally take a look at it, and until your 60s or 70s, we're seeing them in as 50s and sometimes as early as 40s in our patients. But the heart disease thing seems to be occurring about 10 years sooner. So again, even if you have, like I said, zero risk factors for heart disease, completely normal cholesterol, never smoked a cigarette, no family history, normal blood pressure, just because you're positive, you are nearly 2.5, 2.6 times more likely to have a heart attack just because you're positive. So that's why when your doctor is evaluating you to put you on a statin, even though you may not meet the criterion for going on a statin, you may not have a high enough risk factor, just because you're positive, it's actually probably a better idea to be on a statin because they not only lower the cholesterol, but they lower the inflammation inside the blood vessels in the coronary arteries.
So would one of the takeaways be that we as HIV individuals, positive individuals, should take our health a lot more serious than HIV negative, all aspects of our health, but HIV negative.
Yes, I mean this because, like I said, we're 2.5, 2.6, 2.5 times more likely to have a heart attack. We're about 4 times more likely to develop type 2 diabetes over our lifetimes because of some of the HIV medications. We're more likely to have chronic kidney disease because of the HIV medications. Our kidneys normally decline, the function declines about age 60. But if you've been on, like I said, tenofovir, Truvada, Atripla, things like that, you're going to get kidney disease earlier. And we have to make sure that we pay attention to that. Kidney disease increases mortality across the board. So it's not just the HIV process itself, it's sometimes the side effects of our HIV medications and the things that happen, even though you may not have a history of diabetes, just because you're HIV positive, you're more likely to develop diabetes. So those things need to be taken a look at. And one of the emerging recommendations is, if you're on a protease inhibitor, even if you have no family history of diabetes, they might want to check what's called a glycohemoglobin A1C, which will give them what your average blood sugar is for a 3-month period of time. Because we pick up a lot of pre-diabetes, which is the precursor before diabetes. And that's when we make extra recommendations for our patients, like, hey, you really need to watch your concentrated sweets, try and cut down your carbohydrates, make sure you're getting your exercise, put on some more lean muscle mass. Those are the things that we would say that we want to forestall the development of those things. So if we catch someone in the pre-diabetic phase, we want to make sure that we get them before they hit type 2 diabetes. Just being pre-diabetic increases your risk factors for heart disease by almost 2 times. If you hit type 2 diabetes, your risk factors for heart disease is doubled to quadrupled, depending on how bad the blood sugars are.
All right. Well, thank you for those great questions and the answers, of course. We are at time. Any last comments, Dr. D, before we adjourn?
No, I said I'm sorry. This was a lecture that was going to be given also for the healthcare professionals. So some of it was a little dense scientifically, and I apologize for that. But again, the key thing here is that we are living longer just because of the HIV medications. We're dying of all the boring things that everybody else is dying from, but it's happening to us about 10 years sooner and at a higher incidence rate than the general population. So very important you talk to your doctor about trying to minimize your risk factors for diabetes, address cholesterol issues, address your blood pressure issues. Those are all mundane things, but they can go a long way towards decreasing mortality and improving your life expectancy.
Fantastic. Thank you so much. And again, everyone, this has been recorded and it will be posted and edited online and on our YouTube channel. And if you registered through Eisenhower or through the LGBTQ Center, then I will get you that link directly from that as well. So with that, everyone take this to heart, and we'll go back over a lot of this. You'll have a chance to look at the presentation because there's a lot of things that, as you said, there was a lot of information, but a lot of stuff that is pertinent to us that we need to take into account for living healthier and happier. Dr. D, thank you again, and we'll see everyone very soon. Thanks so much.
Thanks.